So is that called a cancer of unknown primary?
Yeah, it fits that.
And what are the most common primary sites for people like Mrs. Adamson?
Well, it can come from different sites in that type of tumor, but again, because we don't know specifically, but it can include malignancies in the gynecologic tract, include malignancies in the breast or in the gastrointestinal tract, and it could include malignancies from the lung too.
How about melanoma?
And melanoma would be one, a skin one.
Dr. Rob, in order to find those cancers that you just named, do you actually have to look for them?
Or use the material to find out that, because you could stain the material if you had that.
Do we have any evidence that Mrs. Adamson's doctors ever looked for the types of cancers, breast, gynecologic, melanoma, in order to rule them out?
Well, I do believe in her journal, once they found out that she had a second cancer, or her calendar, I should say, they did do some workup for looking for another, I think, possible site of extent or tumor by doing some more radiologic studies.
Do we have any evidence that Mrs. Adamson's doctors ever looked for a breast cancer to rule it out?
Not that I know of.
And is there enough information available in this case to rule out the possibility that this is one of those types of cancers you just named?
There is not.
And sitting here today, do you have a different perspective than her doctors did at the time she was originally diagnosed in June of 1992 as you look back over the information we have about her care and treatment?
Well, I think the aspect of what we have is her, essentially a whole timeline of what she went through, which is very different when you're working up a case initially as a pathologist or as a clinician, because you only have what's in front of you or what you know. And if a new tumor or a potentially new tumor arises and you didn't know about it, that would change what you would think. If this person could change what you would think, and you would need to reevaluate whether this was what you thought it was the first time, or if you even wrote down what you thought it was the first time.
And so is that what you've done in this case?
Yes, I think I've looked at her calendar to try to ascertain what they did as a relation to the course of the original diagnosis and other diagnoses.
So let's start by addressing, in your opinion, that there's insufficient evidence to establish here, more likely than not, that she had primary lung cancer. I think we have a slide on the available evidence to prove Mrs. Adamson had primary lung cancer. In establishing whether a patient has primary lung cancer, is it important for you as a pathologist to have pathology tissue to review?
Yes.
And why is that?
Because that's where the diagnosis originates from, of you're looking at the tissue and ruling out other potential sites of where the tissue, or where that tumor may have come from.
Do we have any pathology tissue here for you to examine under the microscope?
Not that I know of, no.
And if we had pathology tissue available, would it be possible to conduct staining tests on it to determine the primary site?
Yes, it would.
So since we don't have the pathology tissue, would it then be important for you as a pathologist to be able to review the pathology reports?
Yes.
And why?
Well, because you would like to know how the case was worked up pathologically and what they knew at the time, because those are the things that affect how they would make the diagnosis. And it changes what you would make the diagnosis on if they list the clinical history that is what they thought, and what we know now would change what we thought of the accuracy of the diagnosis, as well as it would state what they had done to work up the tissue, including immunohistochemical studies or other things that they had pursued in order to determine the primary site.
Do we have any pathology reports?
We don't.
So then is it important as the next step to try to review radiology films like a chest x-ray, chest CT scan in order to establish primary lung cancer?
Yes, it is.
And please explain.
Well, the radiology is the prior step to pathology of what they see and what they may be sampling. And so we don't know how many, actually what she had in her chest if we don't have a radiology film or a radiology report. And we don't know what they were exactly sampling or the location in the chest that was not sampled and what that looked like, because all of those things may enter into whether she had had multiple lesions in the beginning that we don't know about or just a single lesion.
Do we have any radiology films here, Dr. Robb?
We don't.
So now, the next step, without the radiology films, do you want to see at least the radiology reports to get a sense of the location and extent of the cancer in different parts of the body in determining or establishing that this is in fact primary lung cancer?
Yes, and again, it helps frame what is going on radiographically, where lesions are, or what a radiologist would see in different parts of the body.
And can the location and appearance of cancer on radiology films, especially when it comes to lung masses, inform you as to what the primary site of the cancer is?
Yes.
Do we have any radiology reports available in this case?
No, we don't.
Are there a lot of important medical records missing in this case as well?
I'd say that most likely the majority of the medical records are absent.
So even with all of the important medical records that are missing in this case, were you still able to review the materials we do have and glean information about Mrs. Adamson's cancer?
Yes.
So now let's turn to your review of the materials, and we'll start with Mrs. Adamson's personal calendar. And what I want to do is walk through chronologically what we know and don't know about her diagnosis and treatment in relation to your determination of the primary site. Okay?
Okay.
All right. So, Dr. Robb, when was Mrs. Adamson diagnosed with cancer?
Well, she had radiology in May, and then the diagnosis appears to be made in early June.
And do you recall from reading the depositions actually how it came that Mrs. Adamson presented and came to be diagnosed with cancer?
Well, in May she had what looked like a history and physical examination, and I think from the depositions it indicated that it was for insurance to have this history and physical, which is, I think, pretty common for people in new jobs who are being examined, and usually in those things you get history and physical and they're looking for something on your x-ray that might be infectious, like TB. And so she went under one of those screenings or examinations.
And so from what we know, did Mrs. Adamson go to the doctor in May of 1992 because she was experiencing any symptoms?
We don't know anything about symptoms, so no, it looks like she was going for that other reason.
And what do we know from the family members about whether she had any symptoms when she was first diagnosed with cancer?
From my knowledge, she didn't have any symptoms.
What are the typical symptoms of lung cancer?
They depend upon where in the lung it is, and so that many lung cancers that occur what you'd call centrally, like closer here in your chest, in the central portion of it, they may be associated with cough, with coughing up blood. They may be associated with some chest pain, or they may be also associated with a noise that you can listen to. Would be like a wheeze, because an airway may be occluded. Some of the peripheral tumors of the lung can be also associated with pain, because when tumor grows into the outer layer of the lung, the pleura, that can be associated with pain. They can also get fluid around the lungs, which can cause shortness of breath. So there's a lot of pulmonary symptoms that you can see, as well as signs that a person doing an exam could hear dullness in one part of the lung, where there's something that's blocking your being able to hear air move in and out, which may be a tumor. So there's a lot of things that you can find in the lung by doing a history and physical examination that it didn't appear that, well, we don't know what she had because the records are insufficient, but not that I know of were any of those things detected.
And in your experience, how often do patients with late-stage primary lung cancer present with those types of symptoms that you just talked about?
Well, someone with late-stage lung cancer would usually mean it's a larger tumor or growing into a particular area, and almost all of them have some type of symptoms if it's a late-stage tumor.
Does that occur less often when it's actually metastatic to the lung?
It can, because then you may just have a nodule or a few nodules in the lung. It could be late-stage because it's coming from somewhere else, and the lung isn't the primary site, so you might not see those late-stage symptoms.
So is the lack of symptoms for primary lung cancer when Mrs. Adamson reported to the doctor when she was diagnosed with cancer inconsistent, in your opinion, with a typical primary lung cancer?
Late stage, yes.
And in reviewing the testimony of Julie Adamson, is it your understanding as to Mrs. Adamson's personal calendar that this was a contemporaneous record of her care and treatment that was created at the time?
Yes.
And did you see where Julie Adamson in her deposition testified about finding her mother's personal calendar among her things?
Yes.
So let's pull up Mrs. Adamson's calendar and start at May 13th. And does this note a physical with Dr. Steinberg?
Yes, that looks like her appointment to probably be a history and physical, but she just had a physical examination.
And is Dr. Steinberg an internal medicine doctor?
Yes, Dr. Steinberg is.
So now I'm going to put up a board here to help us as we go through the calendar, all of the different doctors and facilities that we're going to talk about that we see in the calendar. Dr. Steinberg, do we have any records from Dr. Steinberg's office?
We do not.
Do you need a minute? Oh, sure, okay. Am I blocking this? No, see, okay. Now, does her calendar reflect what happened after Mrs. Adamson went to Dr. Steinberg for her physical that I think you just discussed as far as being worked up and diagnosed with cancer?
Well, it looks like on the 22nd, she was given news that an X-ray that had been done was abnormal. And so an abnormal X-ray would indicate most likely that they saw a radiographic lesion or lesions within the lung at the time.
And then does it reflect that she was sent for a CT scan?
Yes, it does.
Now if we go over to June 3rd, does this entry say Dr. Rosen pulmonary, 3 o'clock?
Yes, it looks like she had another appointment with a pulmonologist who specializes in lung treatment.
Like lung masses?
Yeah, benign and malignant lung things.
Do we have any records from Dr. Rosen?
We don't.
Is going to see a pulmonologist consistent with, in your experience, with the standard diagnosis process for someone with a lung mass?
It could be, yes.
We go to the next day, June 4th. What does this reflect?
That Dr. Foreman was going to do a biopsy or had scheduled a biopsy of probably the lung mass.
Is Dr. Foreman a diagnostic radiologist?
Yes, an interventional radiologist.
And how would a diagnostic or interventional radiologist perform a biopsy?
At the time, most of the biopsies were performed, it doesn't say, but trans-chest, so they take a needle and stick it into a mass in the lung that they could see on a CT scan.
Do we know from the calendar what was biopsied on this day?
Well, the calendar doesn't say right there.
But then do we know from the depositions and the Rhode Island hospitals that this was most likely what was referred to as a needle biopsy of the lung mass?
That is correct.
You talked earlier about two different needle biopsies, an FNA and a core needle biopsy. In your research, have you found differences in the error rates between FNAs and core needle biopsies?
There's higher error rates in fine needle than core.
In terms of determining a primary site, how much information can you glean from an FNA, or fine needle aspiration?
Depends on the volume that they get, but you could make the diagnosis. But nowadays they would probably do. We would do more workup with immunohistochemistry.
Now, do we have any records from Dr. Foreman available to us? Let's go to June 5th, the next day. What does it say here?
Well, it looks like she had the results of the biopsy given to her.
As a diagnostic radiologist, would you expect that Dr. Foreman would have been the one reviewing the tissue and providing a diagnosis to Mrs. Adamson?
It's unusual for a radiologist to provide that diagnosis, but back then, again, Dr. Foreman may have been the only person listed on the report. Like I said, it can be very uncertain who gets listed and who's going to get the information. But it looks like he did it. I don't know very many radiologists who provide, the first-time diagnosis of cancer if they already have a pulmonologist.
Well, is it also possible, because of the lack of information here, that Dr. Foreman sent the tissue to be reviewed by a pathologist?
Oh, sure. Yes.
Would you be concerned about the accuracy or reliability of the information if it was a radiologist and not a pathologist reviewing the specimen?
Oh, yeah. I mean, I'm believing it probably had to be a pathologist, but it doesn't say.
Do we have any information in any of the calendars or the medical records about any pathologist who ever reviewed any tissue for Mrs. Adamson?
No. We have nothing about any pathologist.
And do we have any record of the results of that biopsy from Dr. Foreman's office?
There's no formal pathology report.
Do we know what Dr. Foreman told Mrs. Adamson here as to the results of the biopsy?
We don't know.
Let's go to June 8th. Brain scan and bone scan. Is this standard workup when someone is diagnosed with cancer in their lung?
Yes, it can be. And this would be looking for if she had metastatic cancer to an area. So it's thinking that if this is a lung cancer, has it spread to either brain or bone?
And is that because the brain and the bone are typical places for metastases from the lung versus primary sites to metastasize to the lung?
Yes, it is.
So at this point in time, do we have any evidence that the doctors are looking for other possible primary sites?
No.
Do we have any information about what doctor actually ordered these scans?
We don't.
Any indication here that they did a mammogram or a breast MRI to look for breast cancer?
There's not.
Would a primary breast cancer have shown up on a chest X-ray or CT scan?
Probably no.
Do young women tend to have benign fibrous tissue in their breasts that could make it harder to detect a malignancy?
On mammography, yes.
Are you familiar with the error rates for mammograms?
Yes.
And have you actually studied that, Dr. Rob?
Yes.
What have you found as the reason for the error rate being so high for mammograms?
Well, it's one of the main things, like pathology having poor samples, is that poor scans can actually be misinterpreted, as well as that the level of tumor can be difficult to separate from the level of surrounding tissue in women who have fibrous tissue of the breast.
And what's the actual error rate that you found at the institutions you've looked at for mammograms?
Well, I would say that, again, it's probably similar to what we see in the rest of medicine, 20% or higher, of disagreements of radiologists looking at it.
Have you found in one study that it could be up to 67%?
Some published work is that, yes.
Yeah. I object. That's not his work.
No speaking. Objection. Sidebar, please.
I object.